السلام عليكم. اليوم موضوع المحاضرة هو البلمونري هايبرتنشن. مثل ما عندنا مصطلح الارتيريال هايبرتنشن بشكل عام او systemic hypertension، عندنا also pulmonary hypertension. Pulmonary hypertension diagnosed when the pulmonary artery pressure increase more than the normal range, which are the 25 mercury at the rest and 30 mercury at the exercise. When the artery pressure, pulmonary artery pressure increased more than these readings indicate pulmonary artery pressure. This diagnosis is caused by either pulmonary arterial hypertension or pulmonary venous hypertension, and we have pulmonary arterial hypertension diagnosed when the patient having vascular resistance increased more than 240 dynams and the presence of low capillary wedge pressure. A few points about capillary wedge pressure. Capillary wedge pressure diagnosed or measured by the special catheter, which is balloon-tipped Swan-Ganz catheter. This catheter passed to the right atria, to the ventricle, and then artery to be tipped and wedged in the narrowest pulmonary arteriole or arteries, small arteries. So this balloon, when wedged in the small arteries, will measure by this sensor of pressure in the tip of the catheter, measure the pressure beyond the balloon, which indicates or give hint about the left atrial pressure. You imagine here when the balloon inflates, this sensor will pressure the pulmonary capillary wedge pressure, which indicate if this pressure is low, less than 15, indicate the pressure in the atria also reduced. If the capillary pressure more than 15 or increased, indicate increment in the left atrial pressure. So the pulmonary arterial pressure hypertension diagnosed when the capillary wedge pressure less than 15 mercury. And we divide the pulmonary hypertension to three stages. Stage 1, or a mild condition, when the pressure about 25 to 34 mmHg, and moderate when the pressure about 35 to 44 mercury, and severe condition when the pressure in the pulmonary artery more than 45 mercury. So these the causes of the pulmonary hypertension. We have the pulmonary arterial hypertension, we have pulmonary venous hypertension, we have pulmonary artery secondary to the lung disease. As we talked in the last slide, pulmonary arterial hypertension, when the arteries having disease, when the arteries having blocked or thrombosed by disease, causing pulmonary artery hypertension characterized by the low capillary wedge pressure and high resistance in condition of primary condition, the familial, or there is secondary to the small thrombi or small arterial disease in case of vasculitis or connective disease like systemic sclerosis or shunt or hypertension or chest infection or some toxins and so on. So this is the arterial. Other cause was pulmonary venous. There is venous pressure increase. Pulmonary vein mean the vein which drain the blood to the atria, to the left atria, mean the pressure in the left atria also increased, mean there is increase in the capillary wedge pressure. Condition caused by left-sided heart disease, like left-sided atrial disease in case of heart failure, in case of left-sided mitral valve disease, MS or mitral regurgitation, or in case of pulmonary venous occlusive disease of the pulmonary vein, or there is pulmonary capillary hemangiomatosis. The third type اللي هو secondary to the lung disease which is called chronic hypoxia. Chronic hypoxia in reverse causing vasoconstriction and secondary pulmonary hypertension, which is condition cause that example of this condition was COPD, diffuse pulmonary lung disease, sleep apnea, alveolar hyperventilation, chronic exposure to high altitude, neonatal lung disease, alveolar capillary dysplasia, and severe scoliosis. Clinically, what are the clinical features of patient with pulmonary hypertension? Most patients of pulmonary hypertension diagnosed at the end stage or lately. Why? Because these manifestations are mixed with the other disease like asthma or hysterical or some condition like anemia and so on, like dyspnea, chest pain, fatigue, palpitation, syncope. And these symptoms, most patients treated as alveolar disease or bronchial disease or depressive or hysterical attack and so on. The signs seen in those patients are prominent or elevated of JVP with prominent A wave if the patient has sinus rhythm, parasternal heave which indicate the right ventricular hypertrophy, and accentuation of the pulmonary component of the second heart sound, and there's right ventricular third heart sound which indicate right ventricular disease. These are the signs and symptoms of the patient with pulmonary hypertension. Investigation. The investigation used, we start in the simple one, the ECG. The ECG finding in patient with pulmonary hypertension include the right ventricular hypertrophy, which shown by the ECG by the prominent R wave in V1 and T inversion, DT inversion in the V1, V2, V3, which is indicated for the patient with the right ventricular hypertrophy. And then the next investigation, the X-ray, which is also useful in case of hypertension, which is showing the enlarged pulmonary artery, and there's peripheral pruning and right ventricular enlargement. This X-ray showing the peripheral pruning indicating that the lung marker not reached the tip of, to the end of the lung. You see, till mid of the distance and disappear. Peripheral pruning of the arteriole or of the marker, which indicate high pressure in the terminal end of the arteriole. So peripheral pruning. In the next slide, which shows the normal distribution of the organ in the chest, and this, imagine the border of the heart, left border. We have the aortic arch, we have pulmonary artery, and then the arterial appendages, and then the ventricle. So this is the site of the pulmonary artery. If we have pulmonary hypertension, so there will be a bulging of the pulmonary artery in the X-ray. This X-ray showing the bulging of the pulmonary artery in the left border of the heart, which indicate pulmonary hypertension. So the investigation used here, ECG, X-ray, and the different diagnosis by the transthoracic echocardiography, which is useful to assess the pressure in the pulmonary circulation by the TR, which is done in invasive measurements, and the advanced or the end investigation with cath, we can use the hemodynamic measurement directly by the invasive procedure really here, right ventricular catheterization. So this investigation used diagnose pulmonary hypertension. Now the after diagnosis we have to treat. Management. As we said, most patients diagnosed at the late stage. So many patients treatment is incurable, and the patient need to treat the manifestation just only. So some condition showing to improve the exercise performance and decrease symptom, and some diagnosis like a patient who the condition is progressive and incurable. All patients should be anticoagulated with warfarin because of the many conditions caused by microthrombi, and also require oxygen, diuretics and digoxin to control the rate in case of tachycardia. Some treatment اللي هو useful treatment هو we have to use calcium blocker اللي هو as vasodilator and prostaglandin iberostinol, and also can be used Viagra or Sildenafil اللي هو PDE5 inhibitor, and also oral androstenedione antagonist اللي هي bosentan have been useful to improve the vasoconstriction in case of pulmonary arterial hypertension. Some conditions require heart-lung transplantation and some thrombectomy in case of there is thrombosis. Arterial septotomy in condition advance to create the shunt between the right and left ventricle to decrease the pressure in the pulmonary circulation. So this management is incurable, just to decrease the exercise performance and to improve the symptom, and some to improve prognosis by a few points. Next topics in our lecture هو sleep apnea. طبعا the sleep apnea is common to be seen in our practice لكنه تكون hidden. Many patients come with this manifestation but not diagnosed until the doctor describe the disease to the patient to detect the patient having sleep apnea without any diagnosis. Sleep apnea من اسمها هي الapnea during sleep, and this usually happen to 2 to 4% of the middle-aged population, and most of the patients in the 4% who get upper airway obstruction during sleep and causing snoring. And snoring is common manifestation in the middle-aged patient, mostly male and mostly obese and short neck. These upper airway obstruction during sleep cause fragmentation of the sleep, causing daytime sleepiness, and especially in the monotonous situation when patient is calm and quiet, so causing increased sleepiness in the day, causing high risk of RTA and even the accident, causing the high mortality. So the sleep apnea mechanism, the obesity hypoventilation syndrome, Beck syndrome, also in case of obese patient fail to breathe rapidly enough or deeply enough during sleep. Many people with this condition also stop breathing altogether for a short period of time during sleep اللي هي obstructive sleep apnea. Etiology. Normally when patient during sleep, the breathing through the nasopharynx by soft palate and the muscle اللي هي palatoglossus and genoglossus muscle, which useful to maintain the patent airway during sleep. In case of hypertrophy of the muscle of the nasopharynx, or there is lipid accumulation, or there is mandible malformation, or there is any narrowing of the nasopharynx, weakness of the muscle during sleep, causing closure of the airway during sleep. What happened when the patient? Now we explain the sleep rhythm. Normally, the sleep rhythm we have two stage. Stage 1 اللي هي non-rapid eye movement sleep اللي هو non-REM and REM sleep. During early sleep اللي يكون patient ما وصل مرحلة الديب sleep، هذا البيشنت يكون يسمونه non-rapid eye movement sleep. هسه بنشوف واحد نايم انت وتسوي فيديو مثلا صوره وتركز على الاي موفمنت. early sleep اللي هو non REM يكون ماكو eye movement. When the patient entered deep sleep and having dream causing rapid eye movements اللي بيسموها REM sleep اللي هو required for the refreshment. هسه احنا من ننام early sleep يكون مو not deep sleep فتحس environment لحد ما تدخل deep sleep. هذا deep sleep اللي هم يسموه REM أو rapid eye movement sleep اللي هو required for refreshment. During REM cycle the muscle of the respiration is weak or there is a blockage of the airway. So the patient having apnea and difficult respiration راح يصير hypoxia and hypercapnia. راح يصير stimulation of the center to get more oxygen so the patient wake. When patient wake return to the non-REM sleep and then patient come again to the REM sleep and the hypoxia occur and apnea occur and tend to the non-REM sleep. So this cycle occur 100 times per night. So شنو المحصلة؟ المحصلة انه المريض ما وصل للريم سليب دائما عن non-REM. شو قاعد الصبح؟ قاعد الصبح يمكن المريض patient unhealthy non-refreshed هدك يحس انه كمان ما نايم. ليش؟ لانه السايكل مال النورمال ريثم اوف سليب not perfect. يكون patient mostly on the non-REM sleep اللي هو non-refreshment sleep. يقعد الصبح يقول ما نايم الا كله ما نايم بس اختنق. هنا الميكانيزم of this poor sleep at night causing sleeplessness وبالتالي increase risk of RTA and even disease. So this condition of many attack of apnea during night, many attack of snoring and dyspnea during night اللي هي تلاحظها هو اللي يلاحظها البارتنر زوجته او زوجها او اللي نايم يمها البارتنر اوف ذا بيشنت يلاحظ هالمشكله يقول لك انه طول الليل سنورينج ونوم متقطع. ايش راح تصير المحصله؟ those patients liable for many complications. Those patients with sleep apnea come with depression, come with high pressure, hypertension, increase insulin resistance وبالتالي البيشنت يكون يدخل بال metabolic syndrome and type 2 diabetes mellitus, death, sudden death, increase RTA and accident in the work, hormone disturbance, stroke, memory problem and unable to concentrate لأنه poor refreshment, snoring and even the cardiac condition patient يكون liable for ischemia and even sudden heart attack. So this is the complication of the sleep apnea. You see, this condition as is simple like having many complications in our body. So we classify this apnea syndrome to the normal, mild, moderate, severe according to the cycle of the apnea per night. And what the factor predisposed to the sleep apnea? Most factor هو obesity. Mostly هو المale يكون المale liable by the hormonal changes or hormonal preference of testosterone which is causing the effect on the upper airway hypertrophy. Obesity also very important factor to increase the nasopharyngeal fat deposition which liable for يكون patient يكون narrow pharynx and therefore sleep apnea. Nasal obstruction or recessed mandibular malformation, acromegaly, hypothyroidism also predisposed to the submucosal infiltration by the mucopolysaccharide which cause narrowing, familial, and use of alcohol and sedative drugs also predisposed to snoring and apnea by relaxation of the upper airway muscle. So these factors make the patient liable for sleep apnea. Clinical feature: the patient come with excessive daytime sleepiness is the principal symptom and snoring is virtually universal. The patient usually feel that he or she has been asleep all night but awake and refreshed. يعني يحس انه نايم طول الليل بقعد هو ما مرتاح. Bed partner report loud snoring in the all body position and will often have noticed multiple breath pauses, apnea. Difficulty with concentration, impaired cognitive function and work performance, and depression, irritability, and nocturia are another feature of the patient with sleep apnea. You see, this disease affects the patient performance and patient concentration and function. Investigation: the patient by history you can by the history of the patient you can diagnose, but the investigation we use the patient by the history we can diagnose the condition even we have witnessed, but we can diagnose by the use of the CPAP اللي هو continuous positive airway pressure اللي هو this instrument. And when you see this measure the oxygen tension in the circulation during sleep before CPAP, you see there is multiple drop of the oxygen, return back, a drop, return back, drop, return back. After CPAP, there's improvement of the oxygen circulation or concentration in the circulation, indicative of sleep apnea. This test is sufficient for diagnosis of the sleep apnea. Other treatment, we try to reverse the factor or the factor that is opposed to the sleep apnea. مثلا the major hazard هو increase of RTA. So all driver not drive until technical relief. All driver with sleep apnea advised to not drive until relieve their condition by either nasal obstruction, relief of obstruction in case of surgery or there is adenoid or so on. Avoid alcohol, and weight loss is very important in some condition of obesity, and CPAP is the magic treatment for this condition. Unfortunately, 30 to 50% of patients don't not tolerate CPAP with mandibular advancement device worn, and some get some improvement for those patients. And this is the device used. You see the tight, and this device used nowadays in patients with COVID-19 to improve the respiration circulation, respiration and oxygen saturation in case of severe dyspnea and hypoxia. So this is the perfect treatment for the sleep apnea, and thank you for your attention.